fun. Okay, so there are many circumstances. What's going on? Many circumstances where an individual might need to have a tracheostomy, but may not have to have a cannula that, for example, could be used for ventilating if they only need ventilating at night. This patient has a hood stomal stent in place. It is, in her case, an 11 millimeter wide by 13 millimeter long stent that can be unplugged for breathing in case the airway is high resistance, for example, at night, and then plugged for talking under other circumstances. It just pops out because there are just two little flanges that are holding it on there. And right now the patient's not anesthetized, so when it pops out, you might cough just a little bit. We'll see. Whoop, there we go. And yeah, just a little bit of coughing. And that's what the stomal stent looks like. It's not a very complicated device. It just has one flange that goes up, one that goes down, and then we can set it right there for the moment. This is just some viscous lidocaine. It is a jelly that anesthetizes mucous membranes. It's very much more friendly for mucosa of the nose and of the airway when you need to have a little bit of numbing, unlike injectable lidocaine, which is actually kind of acidic and can be very irritating to the airway. This is a little bit easier. This is actually a fresh stoma. That's also worth mentioning. I don't know if we have a light. Let's see if we press on here. Can we make the light go on? Let's see. Let's get right there. Let's see if we can do it. No, I don't know if you have a pen light on you.
I don't.
Okay, that's okay. The skin is sewn down to the tracheal rings, virtually circumferentially. Two rings are brought out to either side, and this is just post-op day 2. Is that right? From this wound, so you can't normally instrument a wound quite like this this early, but we certainly can in this context. So the first thing I'm going to do is place this cannula, which I'll show you right here. This is a Portex tight to shaft cannula that allows us to put in a cannula that has very little transverse prominence into the airway without blocking the airway, and then when you need the ventilation capacity of the cannula, you just inflate it with some saline. It's, for whatever reason, doesn't have a valve that will hold just air, so you can insert it in. Now I'll go ahead and pass it in real gently, okay? And it should be gentle enough for you to be able to breathe around it. And you can see she coughs a little bit, but not too bad. But again, this is in a mature stoma situation where the airway is not capable of being disrupted. And then this cannula can be inflated, and the patient can be connected to a ventilator just when they need to be. Part of why I'm doing this is the patient's getting ready to change services, so I want to make sure that the doctors who are taking care of her in the other service can have a reference to be able to look at for her care. Now here comes the important part. So remember I said there's two flanges on this little stomal stent. When you want to replace it, an easy way to do it, there's more than one way, but an easy way to do it is to advance the lower flange like this, just feed it into the channel, and then take the upper flange and push it in so that it kind of comes into the stoma, and then you push it in like that and pops in, and you can see the patient coughs a little bit, and there it is. You know that it's in because it's not sliding out. And if it were only part way in and you kept it and the patient even took a deep breath, you'd see it just pop out. It wouldn't stay in. It's usually pretty easy to be confident that it is in. You also know it's the right size because the tissue is not being indented more than just a little bit, and it's not sliding in and out to be too long. So indented too much would be too short, sliding in and out would be too long, and then going in and not staying in is also a sign of being too short, because it means that the two flanges have not seated on the inside of the airway. One flange is pointing up in the trachea and the other one is pointing down. Now, there's no reason to take the patient through this more than once. You can watch the video again and see how that was done. Remember, you push in the bottom flange first, you hold it down, and then you press the top flange until it's touching the channel. Advance the cannula in a little bit, and then put it in. She's actually going to be changing this in and out for herself in the very near future. She's already seen how to do that. And even the changing of the tracheostomy is something the patient can do for themselves once the wound is well healed and they've gotten some experience with it. Most patients like this one can truly handle that just fine. So I appreciate very much our patient being willing to let me teach on her. I'm hoping this will benefit her specifically in this near future as other doctors take care of her. Thank you so much, dear.